Yeah, so very good evening, everyone. I'm Dr. Samir Arbat, and I welcome you all to the Breathe International webinar series. And today we have an interesting topic, which is rigid bronchoscopy. So I'll share my screen first. So I welcome you all to this webinar on mastering rigid bronchoscopy techniques and challenges. And we have had a long list of registrations. So this slide is an indicator of the number of people who are interested in learning about rigid bronchoscopy and who wish to attend a webinar on this topic. We have attendees from Algeria, Bangladesh, Brazil, Cameroon, Chile, Colombia, Congo, Egypt, Ethiopia, Ecuador, Greece, Guatemala, India, Indonesia, Iran, Iraq, Italy, Kenya, Lebanon, Malaysia, Mexico, Morocco, Nepal, Philippines, Romania, Saudi Arabia, South Africa, Spain, Turkey, United States, Vietnam, and many more. So this slide was for the registrations that were there till yesterday evening. I'm sure there are more people who will be joining today. So I believe we've started on a positive note, and we are lucky to have Dr. Viswesvaran with us, who's the speaker for today's webinar, who will be presenting his talk on rigid bronchoscopy. And we have an esteemed list of panelists over here. And we have Dr. Efsun. She's from Turkey. She's associate professor in the Department of Pulmonology and Interventional Pulmonology, secretary of the Interventional Pulmonology Study Group in at the ERS, and she's the board member of Lung Health and Intensive Care Society. And she's at University of Health Sciences, Turkey, and she's from Istanbul. Next, we have Dr. Byron. He's an interventional pulmonologist and he's editor of the image library for World Association of Bronchology and Interventional Pulmonology, and he's from Quito, Ecuador. Third, we have Dr. Shyam. He's lead interventional pulmonologist and clinical pulmonologist at CMRI CK Birla Hospitals from Kolkata, India. And I'll be your moderator for today's program. So before we start with the presentation by Dr. Viswesvaran, we'll be having a small quiz. This is a questionnaire wherein for each question, the attendees would get the chance to vote for the right option. At the end of the presentation, we'll be discussing the answers also. So I request the technical team to get the quiz voting pad live for question number 1. So this is the question number 1, which is which of the following is not a common indication for rigid bronchoscopy? Is it A, foreign body removal, B, central airway obstruction management, C, peripheral lung nodule biopsy, or D, massive hemoptysis control? So I believe the attendees, you have the option, voting pad on your screen. It can be on your phone or on your laptop, and you can select A, B, C, or D as the correct option. Mind you, you have only one chance to choose the correct option, because once you select any of the options, you can't vote again. So just be careful while you select your answer. So this is question number 1. So now we'll be moving to question number 2. So I'll request the technical team to have the voting pads live for question number 2. Now, coming to question number 2, what is the preferred patient positioning for rigid bronchoscopy? Is it A, supine with neck extension? Is it B, prone with head turned sideways? C, sitting upright? Or D, lateral decubitus? So the question I'll be repeating, what is the preferred patient positioning for rigid bronchoscopy? Is it supine with neck extension, prone with head turned sideways, sitting upright, or lateral decubitus? I hope everyone has put in their vote on the voting pad for question number 2. Now we'll be moving to question number 3. I request the technical team to put the voting pad live for question number 3. So the third question is, what type of anesthesia is typically used for rigid bronchoscopy? Is it A, local anesthesia with conscious sedation? Is it B, spinal anesthesia? Is it C, general anesthesia with controlled ventilation? Or is it a regional nerve block? I'll repeat the question. What type of anesthesia is typically used for rigid bronchoscopy? Is it local anesthesia with conscious sedation? Is it spinal anesthesia, general anesthesia with controlled ventilation, or regional nerve block? Now coming to the fourth question, I request the technical team to get the voting pads live for the fourth question. So which of the following is not an advantage of rigid bronchoscopy over flexible bronchoscopy? Is it A, better airway control during massive hemoptysis? B, ability to use large diameter instruments for foreign body removal? C, superior access to peripheral lung lesions? And D, greater suctioning capability for airway clearance? Mind you, the question is which of the following is not an advantage? It's a trick question. So your option A is better airway control during massive hemoptysis. B, ability to use large diameter instruments for foreign body removal. C, superior access to peripheral lung lesions. And D, greater suctioning with capability for airway clearance. I hope you've put in your votes for question number 4. I request the technical team to get the voting pads live for question number 5. This is our last question. So which of the following is the most commonly used material for modern rigid bronchoscopes? Is it A, stainless steel, B, titanium, C, silicon, or D, carbon fiber? I'll repeat the question. Which of the following is the most commonly used material for modern rigid bronchoscopes? Is it A, stainless steel, B, titanium, C, silicon, or D, carbon fiber? So we have come to the end of the webinar questionnaire, and we'll be now moving on to the presentation by Dr. Viswesvaran. So now I'll be inviting Dr. Viswesvaran, who's an interventional pulmonologist at Yashoda Hospitals, Hyderabad, and he'll be talking on mastering rigid bronchoscopy techniques and challenges. So technical team, can we have the presentation live now?
Hello, friends. Greetings from India. At the outset, I'd like to thank Dr. Samir for giving this opportunity. And today I will be speaking to you about rigid bronchoscopy, diagnostic and therapeutic aspects, the indications and the challenges associated with this amazing procedure. So I don't have any disclosures to make. So we all know that when we go back to the history of rigid bronchoscopy, it all started in the year 1898 with Gustav Killian. He did the first rigid bronchoscopy to remove an aspirated bone from the right mainstem bronchus. And that's how the rigid bronchoscopy started. And he is rightly called as the father of bronchoscopy. So the point of putting this slide is to make you understand that rigid bronchoscopy started as an out of the box thinking. So basically they had to use an esophagoscope to put it inside the airway to retrieve a foreign body. So when it comes to rigid bronchoscope, you need to be innovative. You need to choose the instruments which are needed for a particular procedure and depending upon the indication. Basically, this rigid bronchoscopy are nothing but a hollow metallic tube which are made of stainless steel. They range in length of about 40 centimeter and has got a diameter which varies between 9 to 13.5 millimeter with a barrel thickness of around 2 to 3 millimeter. The important thing about the rigid bronchoscope is that the distal tip is beveled, and this helps to prevent the trauma to the vocal cord while intubating. And if you see the assembly of the rigid bronchoscope, it has got a shaft and it has got a head. And in the head, you have got multiple attachments. So you can connect it to the ventilator. There is an accessory port which helps you to pass the instruments. And there is a main port through which you pass the illuminating telescope, or sometimes you may use a flexible bronchoscope to attain both illumination and to perform your procedures. And the picture onto your right hand side suggests there is a presence of a rigid telescope which is then connected to the light source. And this is how the head looks like. As I said to you before, the head consists of a port which is connecting for ventilator, and sometimes in certain cases you may use a conventional ventilator or sometimes even a jet ventilator. And the accessory port allows you to pass the suction tube, or in certain cases certain instruments like a balloon, and the main channel through which your illuminating telescope is passed. And what you need to understand is about the distal end of the rigid bronchoscope. So there are two different types of rigid scopes. One is called as a rigid tracheoscope. In the rigid tracheoscope, you don't have these fenestrating holes which are used for ventilation. But if you see a rigid barrel with the fenestrating holes at its distal end, then it suggests that it is a rigid bronchoscope. That means you can put it inside one bronchus and can simultaneously ventilate the other bronchus and the other lung. And the distal end is beveled, and this helps to prevent any trauma to the vocal cords while intubating. So this is how the rigid bronchoscopic intubation is done. Generally, the patient is placed in with the neck extended and supported, and then you pass your rigid bronchoscopic assembly. The first anatomical landmark which you will see will be the uvula, and once you cross the uvula and go below, you will be able to see the epiglottis. And what you have to do is you have to bend your scope using your thumb as a fulcrum and make sure that you don't injure the incisors. And then you go below the epiglottis and then see the vocal cord. And the moment you see the vocal cord, you pass the rigid bronchoscope and use this bevel edge to lateralize the vocal cord and enter inside the glottis, and you position your rigid scope inside the airway. And this isn't a complicated procedure. It becomes quite simple as you start doing these procedures. And this is what I was saying about the lateralization of the vocal cord. Now I'll show how we really do the rigid bronchoscopic intubation. What I am showing you currently is the traditional way of rigid bronchoscopic intubation using the rigid telescope. So as you can see from here, I am using the 3-finger technique, and I'm using my thumb as a fulcrum. And as I go inside, I make sure that I lateralize the vocal cord and enter inside. But of late, what we are doing is, instead of using the rigid telescope, we use the same flexible bronchoscope as both for illumination. And the advantage of using a rigid flexible bronchoscope is that it also provides suction, therefore it prevents fogging. And as you can see from here, once I visualize vocal cord, uvula, I'm going and visualizing the epiglottis. Now I'm passing my bronchoscope below the epiglottis. And once I see the glottis, I lateralize the vocal cord with the help of the bevel. And then through corkscrew motion, I enter inside the trachea. And it has to be done gently, and you should make sure that you don't injure the upper airway, because once the upper airway becomes edematous, then it becomes quite difficult for you to perform the re-intubation. And once it is done, now you can see that I am packing up the upper airway so that there is no leakage of gas, and I am connecting them to a ventilator through the ventilator port. The major relative contraindications for performing the rigid bronchoscopy are uncontrolled coagulopathy, patients who require extremes of ventilator or oxygen demands, and tracheal obstruction with a novice operator. And there are certain complications which are bound to happen if you are not cautious in intubating, like injury to the teeth and the gums, the tracheal or the bronchial tears, and sometimes it can result in severe bleeding. But having said that, as you start doing it, you will realize that it's a very, very simple procedure, and all that it requires is a certain orientation to the anatomy of the upper airway, as well as good observation skills, and you need to have enough practice before you start doing it on your own. And the major indications for using the rigid bronchoscopy, as we saw earlier, the era of rigid bronchoscopy started with the foreign body retrieval. Apart from that, it is also useful to achieve hemostasis and provide tamponade effect, relieve airway obstruction from tumors or intubation-related stenosis, facilitate the placement of the tracheal or the bronchial stents, and it also helps in performing endoluminal therapies like a laser, APC, or for using debriding instruments. And in certain cases, when the clots are very thick, you may use it for removing the clots in patients with hemoptysis. So one of the major areas where the rigid bronchoscopy has seen a resurgence is in the bronchoscopic management of malignant airway obstruction. Now I'll take you through a case, and I'll make you understand how we in real time perform a rigid bronchoscopic intubation and perform a malignant airway deobstruction. So here, as you can see from here, initially I am intubating the patient with the help of a rigid bronchoscope. The first anatomical structure I am identifying is an uvula. And once I know that I have identified the uvula, now what I am doing is I'm going below and I'm able to see the epiglottis. And once I see the epiglottis, as you can see from here, I'm putting my pressure on the thumb. I'm using it as a fulcrum. And now I am seeing the glottis. I'm lateralizing the vocal cord, and through corkscrew motion, I'm entering inside the trachea. And once I enter the trachea, then what I will be doing now is I'll be packing up the oral cavity so that I don't want any leakage of the circuit. And now you can see my anesthetist in the PIP connecting this ventilator to the ventilator port of the rigid bronchoscopic head. And whenever we do a tumor debulking at our center, what we do is we put an accessory suction so that we make sure that any bleed that happens, the blood is aspirated and prevents the contamination of the underlying lung parenchyma. And the next important thing is what we are doing is we are placing an endobronchial blocker in the form of a Fogarty. So this is a Fogarty blocker which I am putting it so that when I am doing a tumor debulking, in case if there is any bleed, it helps in achieving certain amount of a tamponade. And once it is done, now you can see that my assistant is securing the Fogarty in place so that once I am out with the tumor, there will not this Fogarty will help in attaining a local hemostasis. So I am placing the Fogarty in place, and once the Fogarty is fixed in place, my assistant is checking whether it is performing. Now you can see there is a big vascular fleshy tumor which is arising from the right main bronchus. Once I know that I am going to deal with a highly vascular tumor, I need to make all precautions. So what I am doing is I am going to tilt my bed slightly to the right so that in case if any bleeding occurs, it spills onto the right side and it doesn't contaminate the normal left lung. In addition to this, I generally place the head end slightly down so that all the bleeding that comes to the trachea and can be sucked by the suction catheter, and it will not contaminate the underlying lung. And before I do a tumor debulking, I'm instilling certain amount of adrenaline, and sometimes we even give a cold saline to decrease the vascularity of the tumor. And since it is a polypoid tumor, what I'm doing now is called as an electrosurgical snaring. And the important point to note while doing an electrosurgical snaring is that the FiO2 requirement should be kept less than 0.4. Anything above 0.4 can make you prone to airway fire. So I make sure that I give a proper instruction and I set the watts in the electrosurgical units around 20 to 25. And once I am very sure that the anesthetist has kept the FiO2 less than 0.4 and the settings are perfectly made and my snare is checked, now I will be going for an electrosurgical snaring of the tumor. So now you can see that I am holding the electrosurgical snare in my hand, and now I am passing the electrosurgical snare through the working channel of a flexible bronchoscope. It just because it's a rigid bronchoscopy, you may not use all rigid instruments. You can use your rigid bronchoscopy as a conduit, and you can perform most of the procedures with a flexible bronchoscopy. And now you can see that I'll be passing the electrosurgical snare, and my assistant is holding the electrosurgical snare in place. And now you can see that the snare is coming out. And once the snare is come out, I again make sure with my anesthetist that the FiO2 is less than 0.4. And once it is done, now you can see that I'm passing the electrosurgical snare. And with the help of an electrosurgical snare, I am snaring this portion of a tumor. Now the tumor is completely kept inside the loop. And once the loop is made, I'm going to snare this tumor, and I'm giving instructions to my assistant that to slowly use this snare to cut this portion of a tumor. So now you can see that I'm activating the cut option in the electrosurgical probe, and I'm instructing my assistant to start slowly snaring this tumor as I am pulling inside the snare. So now you can see that the tumor is being snared with the help of an electrosurgical snare. And once the tumor is cut, you will be able to see that the vascularity of the tumor decreases, which means that it has got dislodged from the main tumor. And sometimes you can use a cryo, and sometimes even with a mere suctioning through your bronchoscope, you will be able to retrieve this tumor. Now you can see that the tumor is being retrieved just with a simple suction through the flexible bronchoscope. And once the tumor is retrieved, I go immediately inside to see if there is no significant bleeding and the balloon is intact. So this balloon ensures that no bleeding spills over to the normal lung. Thereby I am able to maintain the oxygenation and the ventilation during the course of the procedure. Again, I go for a repeat snaring because the tumor was only partially snared. But if you notice this tumor is not a perfect tumor because it is an infiltrating tumor and it is not only a polypoid tumor. So the idea of doing this tumor debulking is to obtain enough tissue for diagnosis. In this case, after the second snare, you can see that I am using the cryo instrument to retrieve this tumor. I make sure that the cryo does not hit the normal mucosa to avoid any sort of an airway bleed. Now the tumor is being removed with the help of the cryo probe. And once this tumor is removed, now I go inside, I inspect the airway, and I make sure that the bleeding is hemostasis is achieved. And you can see there is a recanalization of an airway which has been obtained. I am able to recanalize the anterior subsegment and the posterior subsegment of the right upper lobe. But however, it is an infiltrative tumor which is arising from the apical subsegment of the right upper lobe. So the most of the indications of central airway tumor are to attain a functional efficacy, and you need not have a very good cosmetic outcome, but can still attain a functional efficacy, and that serves your purpose. So in this case, since I know that it is an infiltrative tumor which is arising, and since it is bleeding, what I am doing is called as a double Fogarty technique, where we have put one Fogarty through the accessory port, whereas we are using the other Fogarty to directly go and occlude the site of the bleeding. So this is a technique that we follow, the double Fogarty technique at our center, so that we make sure there is no contamination of airway spillage with the blood after the resection of the tumor. Now, once the tumor is completely removed, most of the tumor is removed, and I am able to attain a functional efficacy. Now, what I'm going to do is I'm using an electrocautery tip, and in certain cases, you can even use an APC to attain the local site hemostasis, so that the tumor doesn't, so that the tumor stops bleeding, and you are able to extubate this patient on table. So now you can see that I am passing the electrosurgical tip, and once the electrosurgical tip is passed, again I instruct my anesthetist to make sure that the FiO2 is less than 0.4. And now you can see that I'll be burning the residual tissue with the help of the electrosurgical tip, so that the chances of the recurrence of the tumor gets decreased. So here you can see that now I'm going to activate, and I'm going to char the base of the tumor, so that the tumor doesn't come back, at least to a certain extent, till the chemotherapy starts taking its effect. Now the tumor is completely charred, so that now I have attained almost near luminal patency, except that I am not able to salvage the apical segment of the right upper lobe, but I am able to salvage the right anterior subsegment and the posterior subsegment of the right upper lobe. And once it is done, now the patient will be extubated on table and will be discharged home the very same day. So in such cases of a malignant central airway tumor, your rigid bronchoscopy plays a vital role, because these tumors can be highly vascular and it can lead to significant bleeding. So all precautions has to be kept in place. So I'll just show you one another case of a metastatic intratracheal melanoma to show you how rigid bronchoscopy is generally done along with an airway stenting. For example, this patient presented to us with a near respiratory arrest, and the patient is having almost like more than 95% occlusion of the proximal trachea by a metastatic intratracheal melanoma. In this case, unlike the previous case, it's not a polypoid growth. So what we are doing is we are directly going for a rigid bronchoscopic debulking, which means I'm using the same rigid bronchoscopic barrel, and through the corkscrew motion, I'm making sure that I'm doing the debulking of the tumor without the use of any electrosurgical snaring, because sometimes after snaring there can be torrential bleed and you may lose the airway. The advantage of using the rigid bronchoscopic debulking is that the rigid bronchoscope also provides a tamponade effect. So any bleeding that happens gets restricted, and you are able to safely do the procedure. So now once the tumor is completely debulked with the help of a rigid bronchoscopic coring or a debulking, the portion of the tumor is cut, and now I will be retrieving this portion of the tumor with the help of a cryo instrument. Now you can see that I am using the cryo probe to retrieve this resected tumor from the airway. And once this tumor is resected, now you will be able to say I'm able to recanalize the airway so that the ventilation gets secured. Once it is done, now I'm using the electrosurgical cautery to burn the tissue, but you can see that the tumor is an infiltrative tumor. So in the same setting, I'm using a self-expanding metallic stent. And the advantage of using a rigid is you can see the stent being deployed with the help of a thin bronchoscope under direct vision. So now I am able to deploy the stent in place. And once the stent is deployed, now you can see that there is almost near complete recanalization of an airway in a patient who had more than 95% occlusion of the proximal trachea. And generally, these patients are extubated on table and discharged the very same day. And this is how your rigid bronchoscopy really plays an important role in malignant central airway obstruction as a part of a palliative treatment and for providing immediate symptomatic relief to this patient. Now you can see that the patient walking back home the very same day following rigid bronchoscopic tumor debulking and airway stenting. So one other area where the rigid bronchoscopy really plays an important role is in the benign central airway obstruction. For example, you can see this patient. This patient came to us with a post-tracheostomy tracheal stenosis. That was almost more than 90% occlusion of the trachea, and it is a complex tracheal stenosis. So initially what we are doing is we are using the electrosurgical instruments, knives, to make the electrosurgical incisions to open up this airway. These are little complicated procedures, and you need to do it very carefully, because if you're little wrong, you may cause a perforation of an airway. And once it is done, now you can see that through the rigid bronchoscope, I'm using it as a conduit to pass the CRE balloon, and I am dilating the stenotic segment. And then what we do is called as a serial mechanical dilation with the help of a rigid bronchoscope. Now you can see that initially I'm using a smaller size rigid barrel, and I'm doing a mechanical dilation. And once it is done and I'm able to have an enough lumen, I'm passing a much larger rigid tube of 12 size to attain a luminal patency. And once it is done, now you can see that I am inserting the silicone stent with the help of a stent deployer under real-time vision with the help of a rigid bronchoscope. So whenever you want to deploy a silicone stent for a benign tracheal airway stenosis, the only way you can do it with the help of a rigid bronchoscope, and your rigid bronchoscope really plays an important role in benign airway stenosis management. This is yet another patient where the patient was having a complete tracheal stenosis. This was selected as one of the best videos in the Bali World Congress of Bronchology and Interventional Pulmonology. And this is an extremely challenging case. So what I'm doing is initially I'm making the electrosurgical incisions with the help of an electrosurgical knife. Then I'm using a CRE balloon and I'm creating a track. And we are doing something called as a retrograde dilation to open up the airway. And once it is done, with the help of a rigid bronchoscope and rigid bronchoscopic forceps, I am placing a Montgomery T-tube, which is a form of a silicone stent with a tracheal limb. Now you can see once the Montgomery T-tube is placed, the patient is removed from the tracheostomy and is able to breathe and vocalize and discharge the very same day walking. And these stents are generally kept for a 6 months to 1 year period. And after 1 year period, we are removing this Montgomery T-tube. And now you can see there is a near complete recanalization of an airway. And this patient is almost around 6 to 8 months on follow-up, asymptomatic without a recurrence of stenosis. So in such cases of extremely complex tracheal stenosis, sometimes your rigid bronchoscopic interventions play a major role in providing a symptomatic relief and preventing the recurrence and getting a successful outcome of tracheal stenosis. Apart from that, this is yet another interesting case where there was a post-pneumonectomy stump blowout secondary to mucormycosis, and you can see there is no bronchial limb left, and there is an ICD which can be visualized through the infected pleura. So to prevent an aspiration of the contents from the infected pleura into the normal lung, we wanted to place a modified silicone Y step. So what we are doing is we are using the rigid bronchoscopy as a conduit, and all silicone Y stents can be placed only with the help of a rigid bronchoscopic assembly. And now you can see under Shyam guidance, under real-time visualization, we are inserting the silicone Y stent. And once the silicone Y stent is placed, now you can see that the infected pleura is completely secluded from the normal lung. Thereby, it prevents the contamination of the normal lung with the infected content from the right-sided pleural cavity. So in certain cases of silicone Y stenting, your rigid bronchoscopy comes to the rescue. But however, the major role is in the management of a foreign body. For example, this patient had a dental screw which went inside during the time of a dental procedure, and now you can see that the dental screw has gone and got deeply impacted into the left lower lobe. Initially, we tried to remove it with a rat tooth forceps. We are not able to remove it because it got deeply impacted. We used a Fogarty balloon to dislodge it. We were not able to. We even passed a rigid bronchoscopic forceps. But the problem with this sort of cases, the rigid bronchoscopic forceps do not reach the periphery airways. Therefore, we were not able to retrieve it. But one thing we noticed in this foreign body was that the distal end of the screw was serrated. So we tried a rigid forceps, but unfortunately in this case we were not able to. And sometimes your rigid assembly can even start injuring the mucosa and cause bleeding. We also tried a Dormia basket to retrieve this foreign body. Still we couldn't, but luckily we were able to hold the serrated edge, and with the help of the corkscrew motion of the bronchoscope, we were able to slowly dislodge this foreign body from the airway. And once the foreign body is dislodged and it is disimpacted from the airway, now we are using the Dormia basket to hold it in place, and we are removing the assembly in toto. So whenever you deal with a case of a sharp-ended foreign body or metallic foreign body where you feel there could be a possibility of a injury to the vocal cord while retrieval of the foreign body, you should be using a rigid bronchoscope to avoid airway damage. This is yet another very, very interesting case of foreign body. We had this young boy who has got a significant upper airway edema, and he was tracheostomized, and unfortunately the tracheostomy limb got dislodged. And when we did a upper airway bronchoscopy examination, you can see that the upper airway is completely edematous. We are not even able to see the vocal cord. It is completely edematous, but somehow we were able to visualize the foreign body. So what we did in this case is we didn't use the rigid bronchoscopic barrel. Rather, we opened up the tracheostomy stoma with the help of a retractor from our ENT colleagues, and we directly went inside. We passed the flexible bronchoscope through the rigid bronchoscopic forceps, and we directly went inside. So that the advantage is that when we pass a flexible bronchoscope as a light source, it also helps in providing suction, thereby preventing the fogging and as well as the lack of visualization because of secretions. Now you can see that I'm able to pass the rigid bronchoscopic forceps loaded with a flexible bronchoscope. And once I go inside under real-time vision, I am able to hold this foreign body in place, and I will be retrieving this foreign body. The technical challenge in this case was we were not able to keep him off ventilation with not more than a minute. So it has to be a quick in and quick out. And luckily, we were able to retrieve this tracheostomy lip. Another major area where the rigid bronchoscopy really plays an important role is in the management of an hemopsis. As you can see from this case here, you have got a patient who has got a massive bleeding. So initially, we are using the cryo instruments to retrieve this clots from the airways. And once these clots are removed, now you will be seeing that there is an active oozing of blood from the airway. So we need to prevent the further oozing of the blood and hemopsis. So in this case, what we will be doing is we are going to go inside and place an endobronchial blocker in the form of a spigot. Now you can see that there is an active bleeding ongoing. So what I'm doing is I'm intubating this patient with the help of a rigid. Therefore, it provides me an easy access to pass my spigots and then place these spigots and occlude the site from where the bleeding is occurring. Now you can see that the spigots are being placed. And once these spigots are placed, now we put a glue over the spigot so that the spigot stays in place and the hemostasis is achieved, and later these spigots are removed. And the major area where the rigid bronchoscopy really plays an important role is in the transbronchial cryolung biopsies. So I'll be showing you how we do the transbronchial cryobiopsies. So we initially intubate this patient with the help of a rigid bronchoscope, and through the side port, we pass the endobronchial blocker in the form of a Fogarty channel, and it is also connected to a ventilator. And my bronchoscope passes through the main working channel. And once this Fogarty is passed, now the Fogarty is checked if it is there in the particular segment where we want it. And we are checking with the help of a assistant. He is checking it whether the Fogarty is functioning in place or not. Is functioning or not. And once the Fogarty is passed, now you can see that I will be securing the position of the Fogarty with the help of a tape. And then what we do is we go inside with the help of a cryoprobe and take a biopsy. There are few centers who do not use a rigid for taking a transbronchial cryobiopsy, but we would strongly encourage to use a endobronchial blocker and if possible a rigid bronchoscope, because that ensures the safety of the procedure. Because there are many cases you may do it without bleeding, but there are certain cases where once you take a transbronchial cryobiopsy, it bleeds significantly, and your rigid plays a very important role in providing airway conduit to do further interventions. For example, in this case, we are using it under a C-arm, and then once we know that we are in a particular position from where we need to take a biopsy, we go inside and we take the cryobiopsy of this lung and we send it for testing. Now you can see that I am visualizing the position of my cryoprobe with the help of a C-arm. I make sure that I am away from the pleura. And once I know that I am away from the pleura, I am activating my cryoprobe, and you can see that I will be removing this entire assembly end block. And once the entire assembly is, now you can see that I am away from the pleura, I am freezing the tissue, and I am removing it end block. And once I remove it from end block, now you can see that the Fogarty will be inflated so that the bleeding, whatever happens, gets restricted to that particular portion of the lung and does not contaminate. So your rigid bronchoscopy plays a very important role in the routine performance of your transbronchial cryobiopsy. This is yet another case which was a highly vascular tumor. So we went inside, we localized with the radial levers, and then we took a cryobiopsy, and we do all our cryo procedures, most of the cryo procedures with the help of a rigid bronchoscopy setup. And in this case, it turned out to be an adenocarcinoma. So this is our interventional pulmonology setup at Yashoda Hospital, Somajiguda, and we have offering for both international and national fellowship programs. And this is our skill lab where we train the candidates as well as we conduct academic programs. So if any one of you are interested, then we are more than happy to have you with us. And this is my mail ID. You can drop in a mail if you are interested in pursuing fellowship, even if you are a national or an international candidate. Thank you once again, Dr. Samir, for giving this opportunity.
So, thank you, Dr. Viswesvaran. I believe that was we saw a variety of different cases explaining how rigid bronchoscopy is useful in cases of interventional pulmonology. So, am I audible?
Yeah.
Yeah, okay. So now moving ahead from this amazing presentation that we had from Dr. Vishwesaran, now we'll have a short panel discussion, and I'll invite the panelists to unmute their themselves. And the first question I'll be asking Dr. Efsun. So, Dr. Efsun, according to you, what are the key indications for choosing rigid bronchoscopy over flexible bronchoscopy in your clinical practice in your region? When do you feel that rigid bronchoscopy is more suitable for a patient rather than flexible bronchoscopy?
Thanks, Samer, for your kind invitation, and thanks to Dr. Viswesvaran for his excellent presentation, which is full of very nice videos. I'm very excited and honored and pleased to be with my colleagues today and chat on that relevant topic. Let me categorize the key clinical indications of our daily clinical practice where rigid bronchoscopy is superior to flexible bronchoscopy into three main groups. First, foreign body removal. Second, central airway obstructions and massive hemoptysis. Let's focus first on foreign body removal. While flexible bronchoscopy can be attempted in adults for small, distally located and organic materials, rigid bronchoscopy remains the golden standard for the removal of all kinds of foreign bodies for both pediatric and adult cases. Its large lumen allows better visibility and access to remove large, sharp, or irregular objects with different kinds of and size of shapes of forceps, baskets, and probes pass through the rigid barrel. At the same time, it provides superior airway control under general anesthesia and also minimizes the risk of foreign body migration to the distal airways. The second category of indications is central airways obstructions. I can say that rigid bronchoscopy is a cornerstone in the management of both benign and malignant airway obstruction, central airway obstructions, because it provides a large, stable, straight working channel for debulking, dilation, resection, and recanalization. To overcome the obstruction, it enables the use of thermal modalities like argon plasma coagulation, electrocautery, laser, or cryo. In addition to these, airway stents, especially the silicones, can be inserted or removed via rigid bronchoscopy. In acute airway pathologies, such as tumor-induced stridors or post-intubation tracheal stenosis, rigid bronchoscopy can be life-saving due to its ability to ventilate the patient during the whole procedure. This is a unique advantage, especially for hypoxic patients. You know, actually, in ordinary surgical procedures requiring general anesthesia, patients with hypoxia or pneumonia are typically considered at high risk for postoperative pulmonary complications. In contrast, patients who gain the greatest benefit from the rigid bronchoscopy are often those with critical central airway obstruction presenting with hypoxia or post-obstructive pneumonia. And massive hemoptysis is another indication where rigid bronchoscopy is superior. It's a medical emergency that requires rapid airway protection and control of bleeding. In a massive hemoptysis scenario, rigid bronchoscopy has several advantages. First of all, its larger lumen enables more effective suctioning of blood and clot and improved visibility, of course. Secondly, it allows simultaneous ventilation, suctioning, and therapeutic intervention at the same time. Thirdly, tamponade, cold saline lavage, thermal coagulation, or topical hemostatic agents can be more effectively applied with the help of rigid bronchoscopy. Most importantly, in cases of unilateral bleeding, a rigid scope can serve as a life-saving tool to isolate and ventilate the non-bleeding side. Finally, beyond these, rigid bronchoscopy is also essential in the management of airway fistulas, post-surgical complications, airway trauma repair, mucus plug removal, transbronchial cryobiopsy, and many rare airway diseases such as plastic bronchitis, relapsing polychondritis, or tracheobronchopathia osteochondroplastica. Thanks for listening.
Yeah, so I believe what Dr. Efson specified is cases where you need good access to the airway, also cases with central airway tumors, and certain specific cases where you can isolate your indicated lung for any chances of bleeding. So, thank you, Dr. Efson. Now we'll move to the next question. So I'll invite Dr. Byron. Dr. Byron, can you unmute yourself? Yeah, good evening. So Dr. Byron, according to you, what are the major technical challenges while performing rigid bronchoscopy, and how do you suggest that we can overcome these challenges during the procedure?
Good evening to everyone. Thank you, Dr. Summer, for the kind invitation. Congratulations to the excellent presentation, Dr. Viswesvaran. Well, very few contraindications exist for rigid bronchoscopy. In experienced hands, rigid bronchoscopy is a safe procedure and can offer improved quality of life in patients with central airways obstruction. The American College of Chest Physicians, the ARS and the ATS require 20 swatch procedures to gain basic competency and thereafter 10 procedures per year to maintain competency. It is very important to analyze each case before the procedure, including patient comorbidities, imaging studies, previous bronchoscopies, technical support, physical space, and equipment. It's imperative that the pulmonologists and the operating room staff be familiar with the necessary equipment. Each device must be properly organized and in good working order. For example, when this procedure is new to an institution, it's advisable to perform several well-rehearsed simulated cases with the operators, anesthesia team, and nursing staff present. This will familiarize each with their crucial role. The procedural plan should be rehearsed and discussed between all staff members. Some limitations, for example, in Latin America to performing rigid bronchoscopy are the requirement of general anesthesia and an experienced operator. For me, this word is very important, teamwork. Intubation requires teamwork with anesthesia, procedural nurse, and proceduralist. The patient position on the bed is of utmost importance to allow proper neck station for easier intubation. The patient should be positioned with the head in the sniffing position with the patient's head at the edge of the bed. There should be a pillow underneath the head and a shoulder roll in place. This position aligns the pharynx, larynx, and trachea. I think there should be at least 3 different sizes of rigid bronchoscopy in an operation room. In general, we can use in men a 10 to 13 millimeters scope, and a 9 or 12 millimeters scope can be used in women. The choice depends on the location of the obstruction or lesion, as well as goals of the procedure. As for ventilation, the particular mode of ventilation will depend on the entire team, their experience and expertise with the different methods, as well as the available options in the hospital. In some hospitals, the preferred method of ventilation is the jet technique. In Ecuador, we use the controlled ventilation. To finish, it's important to mention the technique of dilating stenosilation does not involve excessive force to avoid injury of the normal surrounding trachea. It's very important. We must avoid excessive force when manipulating the rigid instruments. Thanks, Samer, for the attention.
Yeah, thank you, Dr. Byron. So I would concise it by saying that patient positioning, inserting the rigid bronchoscope are major areas, and then it moves on to ventilation, where you need the right team, the right support from your anesthesia to ventilate a patient who's on rigid bronchoscope. So now we'll move to Dr. Shyam. So the next question is for Dr. Shyam. Dr. Shyam, if you can elaborate on what are the common complications which are associated with rigid bronchoscopy, and what are your recommendations to prevent or manage these complications?
Yeah. Thanks, Amir. Thanks for the opportunity to be a part of this event. So I feel whenever you learn rigid bronchoscopy, if you know the right technique, you minimize most of the complications associated with it. Stick to the basics, learn the technique properly. Like how Byron had said, the position is very important. Choose the scope size correctly. I mean, start with the smallest size which you feel can ventilate the patient properly, can you can pass the instruments you require through it comfortably. And position, obviously, like the head elevation, neck extension, so that the oral, the pharyngeal and the laryngeal axis is somewhat parallel, so that you can straight away pass the scope. It's usually the complication rates vary from studies to studies, but the thing is, it is context based. Mostly rigid bronchoscopies are used in patients who are very critically ill, or who have, it depends whether the patient, how stable, if it's an elective rigid bronchoscopic procedure you're doing, or an emergency bronchoscopic procedure you're doing. So complications, it's very tough to generalize them. It's basically, you should view it in the context. But the common complications if we start with the upper, the upper airway, right from the teeth and the lips. So you need to protect the patient's upper lip and the teeth, upper part of the teeth. That's because you can use a gauze piece to use it to protect it, or a mouth guard. And always use your finger. So whenever the patient is lying down, use your finger, middle finger, and place the scope over it, and use your finger as the fulcrum to navigate the scope. That is a very important, very important technique to kind of avoid the teeth and the upper lip injuries. And never force your way. Gently lift the base of the tongue. You see the uvula, gently lift the base of the tongue. And if you feel the camera is fogging, just touch the camera to the mucosa and then again retract it back, so that you need to visualize the whole barrel of the scope. If you don't do it, what happens is the camera slips in front of the scope. You have this illusion that you're already into the trachea, but in actuality, it's just the camera which is gone and the scope barrel remains outside. And that can sometimes, when you force the barrel in, it can damage the vocal cords. So the camera should always be behind the barrel. You should see the whole circumference of the barrel from the camera, the view you get. So gently lift the base of the tongue, proceed ahead, gently lift the epiglottis, and then avoid leveraging the scope, against the teeth or the upper lip. Always use the finger. And even once you reach the larynx, suppose if it is, you reach it, you find the vocal cord is slightly more anterior, don't try to leverage the scope using the arytenoids. That can lead to arytenoid dislocation. So prevent that. Gently try to, head elevate or lift the shoulders a bit, so that you position the axis of the larynx. You can get it down slightly more, and the axis is right onto the scope's axis. And then the other technique is where you slightly turn the bevel end of the scope by 90 degrees and then gently go ahead into the trachea, negotiating the vocal cords. So that is the right technique. So if you do this, the major issues are over. Then it depends on the techniques related to the therapeutic interventions you do. So like, for example, like Vishwesh had mentioned, a huge mass of, the melanoma case where there was a huge mass in the trachea. So in those cases, you need to make sure that, when you have this, when the patient is breathing fine, despite the mass, the patient was alive, he was breathing himself. So that is the patient's tone kept the patient alive. He was breathing because of that. The moment you give a paralytic, the tone is gone and the mass collapses the entire lumen of the trachea, and if you can't intubate properly during that time, you're in a deep problem. So in these cases, what I usually do is I usually nicely give local anesthesia, deeply sedate the patient, intubate, and then tell the anesthetist to give the paralytic, so that you have the scope within the tracheal lumen, and then once the airway is secure, and then you can administer the paralytic, and then so that you're not in trouble. You're already inside the airways. The second thing is, you see whether the compression is an extrinsic compression or a dynamic compression. So that is important. So if you can visualize the CT, study the CT before you actually go in, or if you can even visualize the airway before you actually attempt the procedure with an ultra thin or a thin bronchoscope with just local anesthesia, that would do a great world of good before so that you know what you're getting into. The other thing is, especially when you're trying to pour, the other commonly encountered complication is that of airway tears. So when you're coring, make sure the axis of the bronchoscopic barrel is parallel to the lumen of the bronchoscope, so that, and when you're making the screwing motions, and don't force your way through, just ensure that, if you find a lot of resistance, ensure that you make these screwing movements and then slowly move centimeter or millimeters by millimeter and then proceed ahead. Don't make sudden movements that leads to airway tears. Then the other thing is, when you have a deep stenosis, always, if you see, always keep a tracheostomy, as a standby, especially if they are high-end tracheal stenosis. If you can't intubate, the patient is desaturating, you can always do an emergency tracheostomy. Then comes the complication of airway bleeds and retrieval of foreign bodies. So airway bleeds, like Vishwesh had shown, you can always use a Fogarty. But whenever I try to debulk a tumor which is in the right or left main bronchus, what I do is I actually intubate. I go enter the right main bronchus with the bronchial barrel. So what that does is it isolates that particular side, and also the ventilation. There are ventilatory ports within the rigid barrel where the ventilation can occur. So I isolate. Suppose the tumor is in the distal right main bronchus. So I actually go ahead with the bronchial barrel. I intubate into the right main bronchus, and then I do my so that I'm isolating the right main bronchus so that the blood doesn't spill over to the left main. But at the same time, the ventilatory ports are ventilating the opposite side of the lung as well. And then I do the therapeutic procedure which I need to. Same way, while retrieving sharp foreign objects, like the same thing which Vishwesh had shown. If you, because sharp objects, if you pull it, you might actually cause tears along the airway when you pull it. So try to, proceed with the rigid barrel as far as you can possible into the bronchus, and then withdraw it, take it into the barrel of the scope, and then you can take it out, because that way you can minimize the tears. So these are the common complications, mechanical complications which can occur, and obviously airway fires, all that you need to make sure it doesn't happen. Lower the FiO2 when you're using hot therapies. So bleed, these are the mechanical complications. Then there are complications related to anesthesia that you have to, they are the universal precautions which you take. The patient has to be fasted at least 6 hours before. Ensure alternate airway if you're not able to, secure an airway with the rigid scope. Correct the coagulopathies before. And then if the patient has some kind of arrhythmias and, during the procedure because of hypercarbia or hypoxia, or because of the anesthetic agents, make sure you have adequate backup to correct all those. And always do a post, especially after a procedure, always post the patient for a post-procedure check bronchoscopy the next day. Especially you place stents or you do procedures in the trachea, there's always a chance of pseudomembrane formation, which can also cause the the patient landing up in stridor or respiratory distress. So try to do a post the patient for a check bronchoscopy the next day morning and see if there are a lot of mucosal necrotic slough which is sloughing off and obstructing the bronchus or can cause pseudomembranous flaps. So all those flaps needs to be removed. So these are the common thing. And if you're placing a stent, ensure the correct sizing of the stent, because the stent doesn't open into the trachea, then we are stuck, because that can cause central airway obstruction again. You need to pull the especially the silicone stent I'm talking about. Ensure that the stent blockage doesn't occur. Nebulize the silicone stents. Patients who are with silicone stents, advise nebulization so that there's no mucus plugging and which causes stent blockage. So these are the commonly encountered, but when you proceed to do interventional procedures, you can expect these kind of complications at some point or the other.
Yeah, so thank you, Dr. Shyam. I believe you covered every intricate possibility of a complication, right from inserting the rigid bronchoscope to performing stenting and control of hemoptysis. So yes, patient positioning, the sizing of the stent and the placement of the sizing of the scope and the placement of the scope with access to the trachea are some important points how you can prevent any complications. And now the last question for panel discussion is for our speaker, Dr. Viswesvaran. So how do you ensure patient safety and optimize anesthesia management during rigid bronchoscopy? I believe you've put some light on this question during your presentation, but if you could enlighten us on anesthesia management optimization.
Yeah. Thanks, Sami, for the kind invitation, and happy to see Dr. Efsun and Dr. Byron and Dr. Shyam. So this is the topic which is often least spoken about, especially when you're learning a rigid bronchoscopy, because you're always in the awe of learning the procedure, but not realizing that your anesthetist actually might not be good at managing a case of a rigid bronchoscopy. This happens when you start off a program of a rigid bronchoscopy, because you will be enthusiastic in starting a program. But if you don't teach your anesthetist the basics of rigid bronchoscopy, that's where a lot of problem happens. So I think proper communication with of paramount, because you will be sharing the airway. And second thing is assessment of the patient prior to a bronchoscopy, because most of the procedures that we do actually have are a sort of an emergency sort of a procedure. So many a times you may not actually assess the oral cavity. The patient may be having a denture, he may be having a loose tooth, or sometimes he may be having a trismus, or sometimes there can be a patient might be having a coexistent OSA. So and you need to assess the Mallampati classification. If you don't do this and you start inducing a patient, that is when you actually land up in a catastrophe. So pre-assessment by the interventional pulmonologist as well as the anesthetist about the patient airway status is a must, and we should not rely entirely on the anesthetist, because most of the time it is a procedure which is new for them, especially with the evolving domain of interventional pulmonology. So, and regarding the anesthesia aspect, the most important thing is at our center, we do, though there are proponents for giving a sedation alone and intubate and then following a paralysis. What we have observed in most of our cases is we go in for an upfront complete sedation and a paralysis, and then we intubate with a rigid bronchoscopy. The advantage of doing a complete sedation and a paralysis is that it makes sure that you have a smooth airway and you don't traumatize the vocal cord, because many times if a patient is not completely sedated or the patient is not completely paralyzed, the moment you hit the posterior pharyngeal wall, there can be a gag reflex. And during the time of the gag reflex, sometimes your vocal cord may get injured if you are pushing your rigid bronchoscope into the glottis. So until and unless there is a near complete airway obstruction where I feel like there is going to be a possibility of a difficult intubation. For all the other cases, we generally give a complete sedation and a paralysis, and we go in for an upfront intubation with rigid bronchoscopy. And with respect to the choice, the anesthesia that is used, there are lots of, especially with respect to the ventilation, there's a lot of discussion whether we need to use a jet ventilation or a conventional ventilation. To be very honest, at our center, we don't have an access to jet. Till this date, whatever rigid bronchoscopies we have done, we have used only the conventional ventilation, which is connected to the side port of your rigid bronchoscopy. So the jet ventilation is a luxury, but if you don't have it, it shouldn't deter you from doing an interventional pulmonology procedure. You can do it with the conventional ventilation. And the only other thing which comes with respect to the anesthesia aspect is whether I should give an inhalational agent or should I go for a TIVA. So the preferred mode of the anesthesia when it comes to the rigid bronchoscopy is it's a total intravenous anesthesia. But however, in our setup, we generally use a hybrid model where the induction happens along with an inhalational agent, and then we give a IV anesthetic, and we try to maintain maximum TIVA, but many a times you may have to overlap between the inhalational versus TIVA depending upon the comfort of your anesthetist who is handling. But the point to be noted is when you are going to give an inhalational anesthetist, you are going to deal with an open circuit. So generally that is to be discouraged. And if you have an access to a total intravenous anesthesia, that would be the preferred modality of choice. Another practical problem that really comes is choosing the proper size of the barrel. So if you don't choose, you will be able to choose a small size barrel. You'll be able to easily intubate your patient with rigid bronchoscopy, but you are going to face a lot of problem with respect to the ventilation of airway. There is going to be a lot of a leak that is occurring through the side of the rigid bronchoscopy if you choose a small barrel. The appropriate sizing your barrel makes a lot of differently for your anesthetist in ventilating your patient. So to avoid the leakage of the circuit, it is necessary to pack your upper airway once you have intubate patient with a rigid bronchoscopy. That's what I was showing in the video as well. So we place rigid bronchoscopy, but make sure that we pack it and it is stable, and then we start doing the procedure.
Yeah, I believe we've lost audio and video contact with Dr. Vishwas.
I think, am I on time? Can you hear?
Yeah, if you could, Dr. Vishwas, if you could repeat the last thing that you mentioned.
Yeah, I think there's a network issue. So especially for people who are starting the IP interventional pulmonology program initially, it is of paramount importance that you need to be very sure with your intubation skills as well. So many a times there will be cases where you may feel a difficulty in intubating with a rigid, and if you are not good at your intubation skills, you may actually land up in a complex scenario. So I feel like before you really start doing a rigid bronchoscopic intubation, getting skills in routine intubation training gives you a lot of confidence in handling the airway. Another thing is, especially when it comes to the foreign body, it is always advisable, especially more so for a pediatric population, it is always advisable to have an ENT on the backup, at least on call, especially when you're dealing with pediatric age group, because sometimes when you are removing these foreign bodies, they may get actually stuck at the glottis and can cause a glottic edema and can make your airway unstable. So in such cases, going for an emergency tracheostomy can come to the rescue. And with respect to the use of the ECMO during the time of the rigid bronchoscopic intubation, we never had a need for an ECMO during the time of a rigid bronchoscopic tumor removal. But let's say that you are handling a very high risk case, and if you are working in a center where you have an access to an ECMO, then sometimes you can put these patients preemptively on an ECMO to do the procedure in a much safer way. I think when it comes to the rigid bronchoscopy, it is all about seeing the patient as a whole and not limiting yourself to just looking at the airway. You need to know the underlying cardiac status. You need to know the upper airway anatomy. You need to handle the airway in case of an emergency. And it should be a comprehensive assessment rather than just looking into CT scan and going for a rigid bronchoscopic intervention.
Okay. So that was a very detailed explanation from Dr. Viswesvaran, and I believe we got to know different point of views from Dr. Shyam and Dr. Viswesvaran. I would like to just put in a concise note that what is most important is a very thorough pre-procedure evaluation from anesthesia point of view. Your communication with your anesthetist is of utmost importance, and how much comfortable you are with any emergency intubation techniques, just in case there is a change in your plan of treatment modality while doing rigid bronchoscopy. So thank you for the explanation. We'll have a short go through the questionnaire answers. So these were the questions. So which of the following is not a common indication for rigid bronchoscopy, and the options for foreign body removal, central airway obstruction management, peripheral lung nodule biopsy, and massive hemoptysis. So the answer here is peripheral lung nodule biopsy. Amongst all indications for rigid bronchoscopy, the shortcoming with rigid bronchoscopy standalone is the access to peripheral parts of the lung. So that's the answer for question A. Question 2 is what is the preferred patient positioning for rigid bronchoscopy? This was very finely detailedly explained by Dr. Viswesvaran in his presentation. So you need to place the patient in a supine position with the neck extension so that you get a good access and vision to the vocal cord. And once you enter the trachea, your rigid bronchoscope should be in axis with the trachea itself. So this is the preferred position. And the third question is what type of anesthesia is typically used for rigid bronchoscopy? So it's general anesthesia with controlled ventilation. So it gives you good access to the airway for easy going in and going out with your accessories. You have a proper control on the patient's coughing and going ahead with any modalities through the rigid bronchoscope when you have the patient under general anesthesia. The fourth question was which of the following is not an advantage of rigid bronchoscopy? And yes, the disadvantage is superior access to peripheral lung lesions, while better airway control, ability to use large diameter instruments, and good suctioning capability are advantages for this modality. The last question is which of the following is the most commonly used material for modern rigid bronchoscope? So the answer is A, stainless steel, because A, it is heat resistant, it is good for disinfection, and is also very much reliable. It can sustain any of the manipulations for a very long time, and rigid bronchoscopes are meant to last till the age, and they usually don't get damaged. So stainless steel is the answer to this particular question. And I would like to mention the winners. So the following are the winners for today's quiz. These are the attendees who were the quickest in uh, pressing the answer. So we have Dr. Suman Shil, who's from India. We have Dr. Marcello Ciuffreda, who's from Italy, and we have Dr. Nehmat Ahmad from Lebanon, and we have Dr. Shashank Kumar from India, and no, yes, and Dr. Satyajit Sahu and Dr. Aditya Chawla from India. So congratulations to all of you for answering the most questions correctly in the quickest time. And I'll take this opportunity to invite you all to become a member of VABIP. VABIP is the largest body of interventional pulmonologists with more than 11,000 members across 60 countries and 6 continents. So you can log on to vabip.com and become a member. Now we'll have any questions that we have from the audience. So I have a question here for Dr. Sham. Am I audible?
Yeah.
Yeah. So Dr. Sham, when it comes to rigid bronchoscopy, which are the cases where you feel that we should not attempt rigid bronchoscopy at all? What are the contraindications? Any subset of patients where you feel that we should not go ahead with rigid bronchoscopy?
So I feel, correcting coagulopathies, and if you feel there is so main it is just that here. And then if you feel you can get away with, any patient having a related contraindication to general anesthesia, where you feel you can get away with flexible bronch or high this thing or a general anesthesia would be more detrimental to the patient's health. There you can obviously try with a flexible bronch. But otherwise, rigid is, I feel it's an essential skill for, any interventional pulmonologist to know. There are certain, areas where I feel we can, risk coming off it. One is transbronchial cryobiopsies. I feel we can, especially with, the size 7 Fogarty. I usually use a LMA with a size 7 Fogarty and a pediatric bronchoscope. And then I place the Fogarty, and then I I do the transbronchial cryobiopsies there. And you can even use the angioplasty balloons. So that comes with a guide wire. So, we have my colleague over here in Calcutta, Dr. Arindam, he does it that way, where he doesn't even paralyze the patient. They do it, they place the angioplasty balloon, take cryobiopsies, and since you can see it on the floor because of the guide wire, it's in place. So those are certain subsets where you can, try safely, that is, without compromising too much on the patient's safety, doing off the rigid bronchoscope. And even certain foreign bodies, certain snareable tumors which are there, that I feel might not require a rigid bronchoscope, but otherwise, you can easily, it is pretty essential. It's an essential skill set to have. Contraindications are spinal problems, coagulopathies, mouth opening not great, very narrow mouth opening, especially patients with Sjogren's or systemic sclerosis, where they end up having some kind of central airway obstruction. Those are the broad subsets I wouldn't consider.
Yeah, I believe also patients who have congested upper airway, patients who are prone for obstructive sleep apnea, another subset we need to be careful while going ahead with rigid bronchoscopy. Yeah, so thank you, Dr. Shyam. Next question is for Dr. Efsun. Dr. Efsun, are you there?
Yes, I am.
Yeah, so how many of your procedures, like out of 100%, how many percentage of your procedures are subjected to rigid bronchoscopy in your part of the world, and how many patients are subjected to just flexible bronchoscopy?
My center is a referral center in my country. So maybe most of the bronchoscopic procedures are done in our center, especially in Istanbul. And every year, over 8,000 flexible bronchoscopies are done in my center, including IBAS. And for rigid bronchoscopy, I can say that it is over 800 a year.
Okay, so most of the patients undergo flexible bronchoscopy, and the indications for rigid bronchoscopy are relatively less. Yes, I believe
And
that is, yeah, that is the case at our region also.
yes, and also most of the rigid cases are central airway obstructions, mostly malignant, and then benign, and it is followed by hemoptysis control and foreign body removal and other kinds.
Okay. So thank you for that answer. Dr. Byron, I have a question for you. Dr. Byron, can you unmute yourself? Yeah, so when it comes to your part of the world, how much of rigid bronchoscopy is still with the thoracic surgeon, and how much rigid bronchoscopy is routinely performed by the interventional pulmonologist? Because there are many parts of the world where still now rigid bronchoscopy is only with the domain of the thoracic surgeon. So how's the scenario at your place?
In my country, we do some procedures of rigid bronchoscopy. The majority of the patients are derived to our center because there are a lot of patients, for example, with benign tracheal stenosis. In my unit, we handle these patients. In a lot of cases, the procedure is flexible bronchoscopy. especially in patients with benign tracheal stenosis. We use rigid bronchoscopy in complex case, for example, patients with some rigid bronchoscopies for as benign tracheal stenosis or patients with malignant stenosis or patients with complex stenosis of bronchi. For example, the last month I have a patient with Aspergillus invasive. The procedure was rigid bronchoscopy with mechanical dilatation with balloon Fogarty, with cryotherapy, with cryoextraction. We use APC. The case principle that we manage are patients with tracheal stenosis, the etiology benign.
Okay. I believe globally, all of us are now more adept with doing rigid bronchoscopy, and this specific type of modality is now mostly being done by interventional pulmonologists. And one of the reason for having this topic as part of our webinar series is so that younger people, people who are not yet exposed, get to know the finer details of this procedure. But I believe the proper training, what we would say is a certified training, is what is required before anyone goes ahead with rigid bronchoscopy, because it is a complex procedure. And like Dr. Viswesvaran said, we have to think of the patient comprehensively from the cardiac point of view and all any other complications that might be anticipated. So before we go offline, my last question is for Dr. Viswesvaran. So, Dr. Viswesvaran, according to you, what are the rigid barrel sizes which you would roughly recommend are the correct sizes for a short female or a short male or a very tall male? A rough idea that you
Yeah.
believe should be the sizes
Uh,
with a
Sorry, Samir, I think
bronchoscopy.
I may not be able to connect the video because of
No,
the
no issues.
internet issue.
Yeah.
So generally, for most of the adult male, we choose a 14 size barrel. And even for cases that require a silicone voice stenting, we generally tend to choose a 14 size barrel. But apart from that, for the adult female Indian population, we choose a 12 size barrel. These two are the, I feel, are the ideal ones which every IP suit should have for performing most of the therapeutic interventions of rigid bronchoscopy. Apart from this, I would suggest, like, if you can choose some barrel size between around 8 and 10, that would come handy, especially when you're doing with a serial mechanical dilatation of your airway, especially for stenosis. So I would like to have somewhere rigid tracheobronchoscopes of 8 and 10, and a rigid tracheoscope of 12 and 14. I think these four barrels should take care of most of the adult interventions that we do. And when it comes to pediatrics, I think you need to have an entire assembly of pediatric rigid instruments, because there your margin of error or margin, or to put it otherwise, the margin of safety with a limited number of barrels is a risky thing. So I think with pediatrics, there shouldn't be any compromise on the number of the barrels. You have to be extremely cautious in choosing the right diameter. But when it comes to adult, rigid tracheobronchoscope of 8 and 10 and a rigid tracheoscope of 12 and 14 should complete your assembly.
Yeah. So I believe 10 and 12 tracheoscope should suffice for a lot of procedures that are performed for any central airway tumors. So thank you, Dr. Viswesvaran. I would like to take this opportunity to thank all the faculty members, all the attendees, and the technical team who has been helpful in ensuring that the program runs very smoothly, and the technical backup that is required to conduct a quiz with a live voting pad. So thank you to the technical team also. And we'll be logging off. Thank you all, and congratulations to the winners for the quiz. So this is goodbye from the faculty team over here. So I request the technical team if we can go offline.
you.